So really, I'm going to talk more about sort of good respiratory control and the climate emergency. Again, it's going to be a relatively quick run through. Slides are going to be available at the end. We'll have a look at the current situation. We'll have a look at the clinical carbon footprint, how to improve patient care, and respiratory reviews. And as we've mentioned, that breathing on a hot, dirty planet is quite difficult. So this is a similar map to the one I showed you before, but this is for particulate matter around the Frimley area and Aldershot. And so these are the fine particles that I don't, I'm in Yorkshire, but you and your families and your pets and the goats and chickens get to breathe in. 13% of global asthma is due to traffic pollution, and as we mentioned before, when it gets too hot we get more hospital admissions. Now, one of my frustrations is that I went to medical school back in '97, and every few years we seem to have another report that comes out that says people are dying from asthma. This is from Asthma UK, saying that we've got the highest death toll. This is looking at some of the emergency admissions for adults in the UK over the last 8-9 years or so. And in 2018, 1,400 people died from an asthma attack. And we know that Asthma UK and the Office of National Statistics look at what proportion of those could have been prevented by better care. And to me, it's not just about the care that we provide, but it's about trying to eliminate some of the asthma at source. And that there have been a 25% increase in asthma deaths in the southeast. Now, as I say, I couldn't quite work out whether you're southeast or southwest, but I use the southeast figure for that. So going back to the clinical footprint of GP practices, we've had a look at the 40% of the non-clinical. We're now going to have a look at sort of the 13%, which is MDI or its inhaler use. So this is looking at the whole footprint of a respiratory pathway. So this is the amount of carbon from routine care and from maintenance therapies and from salbutamol inhalers and from the exacerbations and going to hospital and being admitted and the ambulance travel to get there and the attending A&E and any post-exacerbation care. So if we added all of those figures together, we would have the total carbon for a respiratory patient over a year. And actually, we can have a look at one element of that. So this is SABA. And there's a paper that was out last year which looked at the amount of SABA use. Now, I think that in practices we've often thought of SABA overuse as 6 or more, or 9 or more, or 12 or more inhalers a year. Actually, 3 or more doubles our exacerbation risk, or rather it doubles the patient's exacerbation risk. And this is regardless of severity of illness. So the more SABA that we provide or we prescribe doubles the risk of an exacerbation. So actually, is there a way that we can reduce over-reliance on salbutamol? Another is looking at maintenance therapy. So is there a way that we can, if we've got people who are not well controlled at the moment, and so we're giving them sort of high carbon inhalers with inappropriate care, actually we've got that double whammy of worse emissions and worse control. So we have more exacerbations and so there's no patient benefits and there's no carbon benefits. So the routine care part of this is what we were having a look at in terms of if we can decarbonise our practices, our non-clinical carbon, actually we can reduce that down pretty low. If we can reduce the amount of over-reliance on salbutamol, we can reduce the number of exacerbations. So actually we can start to see how, if it's poor control, which is bad for our patients, it's actually also bad for the society, and from a climate change point of view, it's bad for the planet. So one of the questions people ask is why should we switch inhaler devices? Well, as I say, asthma care is still pretty poor in places in the UK. I'll come on to inhaler technique and discuss how good or bad it is in a moment. It's also looking at the difference between the MDI and the DPIs in terms of whether they can be safely used by the majority of patients and being better environmentally. So this is the carbon emissions from an inhaler. This is looking at the salbutamol ones. So a Ventolin, as I say, it's around 25 kilos, 25, 29 kilos per pack. The alternative is about a kilo a pack, and of course there's no propellant in that. So what this means is that, you know, one Ventolin inhaler is about 175 miles worth of car travel in terms of emissions. So that is from here, or from where you are, all the way up to Sheffield. For the dry powder one, it's a bit like going from Frimley up the road, and the place that I found up the road that was about 4 miles. I mean, you could almost walk it. That's the sort of level of difference between the two, the emissions from the two inhalers. So salbutamol overuse. The papers are linked at the bottom. In the UK, on average, patients receive 6.5 salbutamol inhalers per patient per year. So 3 or more doubles their risk of increasing their exacerbations, increases the number who turn up to see us in practice, and increases the number that get seen both in hospital as inpatients, but then also in the outpatient consultations as well. Unfortunately, in the UK, most of the salbutamol that is prescribed are MDIs. So even if we wanted to, even if we thought that lots of salbutamol was good patient care, good outcome for patients, actually we're prescribing some pretty harmful inhalers as a result. So this is a list based on the different types of salbutamol inhaler and their emissions. And again, you get a copy of this at the end, so that down at the bottom are the dry powder ones. And it depends on what type of propellant the inhaler has in it as to how good or bad it is for the environment. So even if the only thing that came out of today was people said, right, we're not going to prescribe Ventolin, Evohaler anymore, we're going to use any of the other ones, well, we're a step further forward. So even if people wanted to use the MDI inhalers, go for the less damaging version. Maintenance inhalers, I thought somebody might have put a link on to greenerinhaler.org. This is a very, very, very useful website where you can have a look at all sorts of different inhalers and what the CO2 emitted in terms of propellant is for each of the inhalers. And there we have on the list Clenil. I suspect that most of us use Clenil quite a lot. Actually, we can make some relatively simple changes to some lower emitting inhalers. But how are we going to choose? Now, this is the nice guidance, or they created some guidance, which is a decision aid, which is at the bottom of the screen, or the link to it. And this is really based upon the inspiratory effort and speed and the coordination between inhalation, the inhaler and the breath. And so basically anybody who's on this side of the inhaler, which is can you breathe in through your mouth quickly and deeply within 2 or 3 seconds, can actually try a DPI inhaler. So actually most of our patients can breathe in quickly and deeply within 2 or 3 seconds. So really the only question that we have to ask when it comes to could they use a DPI is that one question. So if again from today we put on our templates on system 1 or whichever system you use, that one question when it comes into the to the asthma review, it means that you know that a DPI could be suitable and appropriate. So when it comes to asthma reviews, the Royal College of Physicians has 3 questions in terms of how well controlled is asthma, and if asthma is not well controlled, there we go, we've got an immediate flag that says, well, maybe we need to try something else because whatever we're doing so far isn't giving us good control. So we've asked one question about how quickly can they breathe in. We've asked about how their control is, and then suddenly we're on to, okay, well, we've got some alternatives that could improve patient outcomes, improve the clinical situation, and do it in a lower carbon, less environmentally harmful way. So this is about checking the inhaler technique, which I'll move on to in just a second, discussing how are they getting on with their inhaler at the moment. From an asthma point of view, or from a respiratory point of view, the best inhaler, in my opinion, is the one that works for the patient. So if you've got a patient who's got fantastic control and says, symptoms, what symptoms? And they're on an MDI inhaler, leave it. Do not change it if they're doing well. We're not wanting to push people's control out of the window. This is more for those who are either new patients, those who are not managing with their inhaler currently, not getting good clinical benefit out of it, having increased exacerbation rates, having 3 or more salbutamol a year. So this is not about the well-controlled respiratory patient. We've got trigger avoidance. We've already made mention about sort of air pollution and car travel, for example. And then at the bottom of the screen, in terms of asthma reviews, it's looking at that over-reliance on salbutamol. Now, I was going to do a survey for this, but actually it's probably easier. If I said to you what percentage of patients can't manage their inhalers, or rather, if you ask patients how do you manage with your inhaler, 90% of them say that they've got a good technique. If you actually assess that technique, it's 9%. So objectively, only 9% are using the MDI inhalers correctly. So most people have got a pretty poor technique. Now, the DPIs are not that much better. They're only 30% of people have got a good technique, but actually that's a damn sight better than less than 10%. The other problem, though, is that if you do assessments of clinicians, GPs, nurses, people who work on respiratory wards, and measure and assess their technique in terms of training of patients, actually, unfortunately, we're pretty bad as well. I'm just writing up a paper at the moment, and the people who are best are actually the respiratory nurses. So for the GPs that are in the room, if you're good, brilliant. If you want to brush up your technique, fantastic. But if you're not, let somebody who is good do it on your behalf. And generally speaking, the practice nurses are better than the rest of us. So if there's practice nurses on here, fab. And there was a good study which said that actually the MDI technique hasn't improved over time. So whatever we've been doing over the last 20 years hasn't got through to patients in terms of their technique. So it's a bit frustrating that we've spent goodness knows how many billions in terms of trying to educate. The Asthma UK calculated that we spend £1 billion a year caring for people with asthma, and I could argue that we're not spending that correctly if our training of patients is not particularly great. The next is that MDIs are really only useful with inhalers. So if we don't give an inhaler to everybody who's got an MDI, actually we end up missing a bit of a trick. So when should we watch and observe an inhaler technique from a patient? Well, actually it's every consultation that they come in relating to their asthma, and actually I would suggest that that's a good time to talk about air pollution as well. And I use sort of some local maps for where I work and say, this is what the air pollution is in the area, and actually these are some of the contributors to it. So certainly every consultation that they talk about asthma, certainly when there's been a deterioration in asthma control, and then there's that annual review or when the device is changed. I would not advocate changing anybody's inhaler device or the delivery device without training of how to use it. So as I said in the previous talk, our average footprint is about 35 kilos a year. A Ventolin is between 25 and 30 kilos, depending on which methodology you use. But actually, when we start looking at the difference from a patient's point of view, this is the annual carbon footprint. So if they are using the Relvar and the Ventolin Accuhaler, we can get a total footprint of about 17 kilos per year. Conversely, if we use the meter dose equivalents, we're about half a ton. So the same drug, just being delivered in a different way, we can see the magnitude of difference between the two. And so part of that is then, can we reduce the need for inhalers in the first place? Actually, can we reduce the incidence of asthma? I've already said that 13% of global asthma is because of transport and traffic related air pollution. I'm not suggesting that everybody should go out and buy an electric car today. If you were going to walk or get an electric bike, I would strongly encourage that, because that's then going to start to have an impact on air quality. And if we can get our patients to do the same and our staff to do the same, actually we can start to reduce the incidence of asthma in the first place. And the next is, can we reduce the amount of SABAs that we're prescribing by actually getting better maintenance? Well, absolutely we can. And then certainly in terms of the co-benefits of non-pharmacological approaches, so things like green prescribing, things like exercise-based, things like pulmonary rehab, are all really, really useful, and they don't involve any drugs at all. This is a slightly busy slide, I apologise. This is saying that nationally the GP contract says that the NHS is committed to reducing the carbon impact of inhalers used in the treatment for respiratory conditions by 50%. So I've put the italics on the bottom line of where it is clinically appropriate to do so. So this isn't about changing every patient, it's about changing the appropriate ones. And then on the other side of the screen, I think somebody might have made a mention of the low carbon inhalers available on the Frimley formula, and there's the web link at the bottom to your CCG website. I'm going to use this slide again. I'm not going to make any apologies for duplication. It is, I think, our responsibility to talk to our patients and tell our patients about air pollution, the causes of it and the effects of it. We are that trusted voice, and this is something that we can do in our practices, in our clinical approach on a daily basis. This is something not to read now, but these are a whole host of sort of sustainable QI, quality improvement projects that are based around respiratory care. I will let you have a copy of this on both the Green and Practice website and on SUSQI. A lot of things that we can do in practice between ourselves as part of that quality improvement for patient outcomes. And what else could our practices do? Well, we've heard about some of these. We've heard about the Green Impact for Health scheme, and I know that some of you have signed up to that already. This is looking at sort of environmental sustainability or environmental impact collectively. We've mentioned sort of declaring a climate emergency, and the question that I would say is, well, why not? Why are we not telling our patients that this is something which we recognise as important? The population are recognising it increasingly, so we can use our voices to add that weight. And then there's a Clean Air Champion Guide for health professionals on the Clean Air Hub. Certainly locally, we've got some funding in the northeast to send clinical staff on this, or have had people sent on it as a result. And I think we're just waiting for the next courses to be up and running. So in summary, for me, this is about the right inhaler for the right patient at the right time. This is not about a blanket switch, and I would strongly advise against that. We need to be thinking about reducing the prevalence of respiratory conditions. Could we reduce asthma in North Hampshire by 13% by changing our travel methods? I would certainly hope so. We need to get better at inhaler technique, and the Asthma UK videos are something which I use and send out to every patient. Again, this is a very low carbon way of getting some education out to patients. I tell them that I want them to be so good that they could star in the next video. I've not actually taken them up on that offer, but I do get to then watch how good they are. And we need to get better at reducing the salbutamol over-reliance or overuse, and improving the maintenance therapies, but we can only do that by looking at the whole respiratory care pathway. So for me, I think that we can reduce both disease burden for patients and the carbon footprint of treatment through the inhalers as well.